Let me know when we're in a minute.
I'll let you know.
We're 10 seconds away from a minute.
All right.
Oh.
All right. Stop chest compressions. Check for a pulse. Do we have a pulse? And let's check our rhythm. It looks like we have VFib. We have a shockable rhythm. All right. Let's hook up the pads.
All right. Hook up.
Pads are hooked. Charge to 200. Hook up the pads. Charge up.
150. 150. Charging.
Okay.
Charging. I'm clear. You're clear. We're all clear. Tell me when.
Clear.
All clear.
Shock.
Shock now.
No shock delivered.
No shock delivered.
Oh, sorry. No shock delivered.
No shock delivered.
Compressions?
No shock.
All right. Restart CPR. Let's go. CPR continues.
Do you need a switch out?
Let's give it.
Nisha, can you prepare on the other room?
Oh, actually.
Why was atropine? Is there something wrong with the machine?
The pads are hooked up here.
All right.
Just continue CPR.
Just continue CPR. Someone let me know for 1 minute.
I'll let you know now.
Jonathan, do you need this? Are you getting tired?
All right. All right. So let me know when we're at another minute.
I'll let you know now.
Just to recap, we've given one of epinephrine, we've given amiodarone.
The test one was.
And let's also add history.
seconds
What
for pulse
medication,
check.
medications the patient's on that we should know about.
Doc, pulse check.
300.
So it's gonna
1 minute.
Stop,
Pulse
check
check.
pulse.
Oh, there we go.
All right, any pulse? We're still on VFib. Let's shock.
Shock. Charge.
Charge 200.
200. Increase it to 200.
I'm clear, you're clear, we're all clear.
CPR.
Hold up.
What's
Did it we shocked? Did it work?
Yes.
Shock going?
Yep.
Okay, check the pulse.
Which one are we looking at?
no pulse?
No pulse. All right, continue CPR. We switched off. Has it been 3 minutes since the last administration of epinephrine?
Yes, doc.
All right, let's give another 1 milligram of epinephrine.
1 every. Nisha.
Excellent, we're getting entitled CO2. Good job. There we go. Let me know we're at 1 minute.
I will.
Oh, we got a rhythm there.
All right.
No, just
Okay,
continue.
we have
Continue
spontaneous
CPR.
group. Stop, check
Hi, I'm
rhythm.
EMT. I'm the
Excellent.
Largo EMT.
Excellent. Do we have a pulse?
Somebody give me a report.
There is a pulse.
We have a pulse, we have a rhythm.
What's the rhythm?
Rhythm is sinus.
Sinus.
Set.
Okay.
We have a 6-year-old male, came in for endoscopy, loss of airway. We tried to intubate, difficult intubation. Did not visualize anything, was difficult to mask. It's now easier to mask, but I could not visualize the airway on laryngoscopy. And we think he needs a definitive airway. So we'd like you to trach him if possible.
Okay, we'll take over.
All right. All right.
All right, awesome.
Good job, guys.
Going under pressure.
Give him drugs. 500 cc fluid bolus and drugs.
Doc, just to recap, we gave 2 milligrams of epinephrine.
Are we still going? Is the thing?
Yeah,
no,
We're
I
done.
know.
We're done. All right.
Now we will debrief.
All right. We're
Let's
good.
debrief real quickly. So we want to debrief with the team that was around and all of you participated. So we usually start with our debrief, like what went well. So I just want to go around the room and just tell me what went well for you. It can just be one thing that you can say what went well for you during this critical event. We'll start with you since you're part of the core team.
I would say the fact that someone came in, I felt like somebody took charge.
Okay.
At first it was a little like, okay, it wasn't, I guess, designated who was gonna take charge, but I could actually feel who was the person that was controlling it.
So you have a clear leader.
Yeah.
How about you?
I think the best part is the communication and delegation. So if you have a person taking over, yeah, things will be smoothly like.
Dedication, communication. All right, great. How about you?
Communication was key.
What's key for you?
Communication.
Okay,
We were told.
good. So you're talking to each other. It's good. It's always good. Yeah. How about the rest of the team? We'll start with you.
I like the rapid response of anesthesia being there immediately to come in to help. And then ENT coming in an expedited manner.
That helped. How about you? What went well for you?
I guess like Jonathan said, communication, everybody knew what they were supposed to do, as opposed to everybody just jumping in.
Okay, taking different roles.
Yeah, the different roles of everybody.
How about you?
And I also, the communication, but I like when John would say, you do this and you do, so he designated who he wanted to do what.
Okay,
So that made it clear.
you made it clear for everyone, clear directions.
I like the transition from the core team to the anesthesiologist. Because when it came into control, and it was like kind of really.
You had directions, okay. So that transition was good. So you always knew who was in that leadership position, right? And that's what we would like to see. Even when ENT walks in, you should only get orders from one, right? Because otherwise you might get double orders. And then we just always want to say, is there a leadership transition? So if your anesthesia is just going to do airway, and then your ENT is going to lead, or ENT is going to do the airway, and your anesthesia is going to lead, you always want to make sure that you have that clearly defined leader. So we're not missing any of the orders, or we're not getting multiple orders. You're like, you have the epi and atropine on which one do I give? So that's what we will have to avoid. Good. Bye. How about you?
Well, it wasn't like everybody was screaming over top of each other.
Okay.
Or, talking over each other. There was one direct order person or two people that were like actually talking, communicating, giving the orders, so it wasn't like too much, and then you can't understand what's coming in.
And I don't know if they actually do this in a code, but when Dr. Alexander would tell us which drawer to find the stuff, that was very
No, you don't get that.
The tech here, the tech would be able to give me stuff, yeah. Because the tech normally comes up.
There'd be another anesthesia tech or another anesthesiologist, which is why we gave you time to kind of open up the drawer and see what was in it. But yeah,
And it's labeled on the outside too.
Yeah.
There's pictures. We're gonna take them. Yeah. They did a great job with it. Looks nice.
How about you?
Communication.
Communication is the All right. So anything else to add from?
Dr. Alexander.
Close with communication. So when an order was given, someone said, I gave this, so that was excellent. Part of team steps, fantastic. Also, I think there was, when I came in, I got a great SBAR of what was going on, so I got to figure out what was happening really quickly. I walked into a scenario where the patient was getting positive pressure ventilation. I think you guys had things together before I even walked in, so it was nice to make that nice transition of things were going on, things were happening, and take over from there. So that worked out really nicely. So you guys did a great job.
and I'd like to say, yeah, you guys did a wonderful job, and also calling for help immediately when the team came in and they saw that there needed to be a reach out to overhead and to anesthesia. That happened really quickly, and also the call to 911. So
yeah, 911 I felt like was called, but there's also like someone supporting, right? Because you guys were all on the patient. It's like, okay, I'm gonna call ENT. 911 needs to be called, so I'm gonna call. And so it's not even like, do you want 911? It's like recognizing I need to call 911 and just say I've called 911, so the team is aware there's more help coming. It kind of reduces your stress level too, right? Because when it's like, okay, someone else is coming. I just need to get the patient stable enough so they can get to their level of care that they need. Right? Any improvements? Anything else?
No, you guys see everything.
No improvements?
No.
No, I was just giving him a chance to say what went well for him.
You guys said
anything to add? And so what else? What can we do better?
No supplies, I think, would help speed things up.
Knowing the supplies? Oh, okay.
Yeah. Even if we don't have that second person there right away, to kind of just be familiar. I need to look at it and make sure.
And kind of make sure. And this is why we do this, is to see, do I know all of my equipment that I have? Is it readily accessible to me? So just kind of like when you have downtime where you just kind of just open up the cards and just kind of look through it, it's really helpful. And one thing we did in the CDU is like every nurse now goes, like they rotate every month, checking the crash card. It has to be checked anyway. So every nurse kind of rotates, so then two nurses rotate, and so they can just kind of document, so they know each drawer what it has. So that's something that you guys can do as well. Just kind of get familiar with your, what resources do I have in my department, what can I do? All right, what else?
And just to add to whatever Dahlia said is, you don't want to be in that predicament where you have this situation happening in your department, and bad outcome happens, and it's the feeling that you would have, oh, I wish I knew where things are. Like, I wish I knew that I was able to understand what the physician was asking me. So those things would come to you as a human. So part of fixing it, I would say, is, I know we are all busy, but take time to understand where things are. Like, part of safety threats are not knowing your resources, where they are, not actually how to use them, but where are they located, and are there any barriers to bring them to the room? Is there any system issue? Like, when you push the code button, if it's not working, that's your issue. So those are the things. Do I know where things are? Do I know if they're functioning before the day start? Did I check those things so I'm not running into this safety threats that I'm gonna be like, oh my goodness, someone died or something happened because we didn't do certain things. So just take it up on yourself to learn certain things. Don't wait for education department to come and teach you, but at the same time you could just take over. Hey, I think I need to know how the difficult airway looks like and what things in it. So it's just another layer for yourself to say, you know what, if bad things happen here, I don't know if I'm gonna live through what feeling that way. So that's why we want to make sure that you know where things are and whatnot.
Let's add when the code, or someone said I'm going to get the code card. When you hear the one person, two people, you don't need everybody to go to the code card, right? Some of you should leave and go, at least be close by, especially to relieve the person doing CPR. Remember, CPR is a lot of work, guys. So you should at least rotate through that. Make sure you do that. The two people going to get the code card, somebody went to go get it, so that's okay. If somebody else thinks we might need the airway card, go ahead and get it and have it close by, because you know where we got to get it from. So you can just move it here in the hallway so that it's ready. But I don't think everybody's going for the same thing. Don't be afraid to come in the room. Come in the room, because they're going to need you to do something, right?
Yeah, that's true.
One thing I would add is just to make sure when you're doing CPR to have the backboard. You guys know where your backboard is for your desk, back of your cart, right? So just remember just like, if you have to start CPR maybe on the next just round, or just kind of like, I'm ready to slide it in, slide that in. So when we brought the equipment in, he was hooked up, but it was a lot of dotted lines. So look at your monitor and just kind of listen to it, because it wasn't on because the connection wasn't tight enough. So he had the pads on, but the connection wasn't tight enough, so you didn't see. That's why I said shock was not delivered, because you weren't hooked up, so you weren't seeing the rhythm. And I would put, if it was me, I would put that a little bit in the front, because whoever's giving you orders for your defibrillation, for any energy, should be able to visualize it. So you should be able. Yeah, I would put it at the feet. If he's leading from the head of the bed, then it should be at the feet. If he's airway and somebody's leading, then you can leave it. So it's just in the visual of the person ordering. So he's saying, I have V50, because he's got no confirmation here. But if you're ordering any energy, it should be from the machine itself. So you should make it visible to him. So that's your mutual support to your leader to say, I'm going to put it down here.
So initially when we come in, this is like our regular monitor. Was this how the simulation was set?
Yeah, so this is your regular monitor. So someone asked, like, which one do we look at? So when you're delivering energy, you should look at your defibrillator monitor, what it's saying. It should match, right? But you should always look at that one to be able to give the energy. So then your machine, again, does not talk to you. I don't know if that's what you're used to. It doesn't say shock delivered. So it just will say 0. So that's why I wanted you to make sure you're comfortable with your machine to say, if it was delivered, it will say shock 1, right? So that's why, and then you'll see the strip with the line where you delivered the shock. So just kind of caveat to that.
So when you brought the machine in, was something connected? Well, I don't know.
It was not hooked all the way.
Yes, so your machine is going to be on the tester. So you just unplug the tester, and then you plug it to your pad. So you put the pad on, and you plug it in. but when you plugged it, it wasn't tight enough, so you weren't seeing any rhythms on there.
But in real life,
So
you're
in
gonna
real
open
life,
up the
thank you.
pads and put it on
Thank
the
you, because that's
patient.
what I did. I opened up the pads. I didn't know the pads were on. I was like, hold on, let me put the pads on.
I said, yeah,
Yeah.
the pads are on, yes, and that was your connection, that's why,
Okay.
but it
So
just wasn't
for
tight enough.
simulation, this was like this, and then Nikki came in with the cart, and what did you connect?
No, it was like this.
like this.
It wasn't
It was connected to the tester.
It was like
Okay,
that.
thank you.
So she kind of put the
Okay.
pad on, and then she took the tester off and connected.
Thank you.
We just needed to make sure the
It
connection
wasn't
was
fully.
was tight enough. So in real life, that's why I bring it up is, in real life, just work your way back, right? Because that's what we would have done anyway. If something wasn't connected, we would go, let me check the patient, okay, my pads are on, and you work from the patient to the machine. So just kind of think about those things as well. So if you're on the monitor, you're not familiar with it, just speak up, right? To say, does somebody know how to do this machine? Because I'm not getting a rhythm on here. So you can kind of troubleshoot it together. So that's what really matters, right? Because we want to have mutual support of each other to be able to do that.
I have a question. In ACLS protocol, we do pulse check every 2 minutes. Is there a reason why we do it every 1 minute?
So that's how I normally do it, but normally ACLS, yes. I
Yes,
check.
ACLS,
That's a separate
did we
break.
check every minute? I missed that. Yeah, it's every 2 minutes, is where we check, and if there's a rhythm change, you can do a pulse check as well. So what they're saying is like, if the rhythm is the same, you can actually even charge the machine and then check the rhythm. Because what you're doing at that point, okay, yes, it's still in VFib, so all you have to do is just shock. So we're minimizing that pause from pulse check. So when you guys recognize it's a shockable rhythm, so we're off, hands off for a little bit longer than that 10 second that the ACLS AHA recommends. So stay on the chest until your monitor nurse is ready to defibrillate. Then she says clear, and then you clear off from the airway and the chest compressions. And then you switch out. Like Debbie said, like that's a great time to switch your compressor.
And for John, like if you have that thought in your mind, just say it. That the hierarchy is, there's no hierarchy here. Dr. Alexander you can say, Dr. Alexander, ACLS guideline, it's every 2 minutes. Is there a reason why we're doing this? So try to communicate that, so you don't have to keep your thought to yourself because you think it might be wrong and something's going to happen. No, it's just say it out loud. He would answer with whatever rationale he has, and then you can proceed with the situation. So just don't hold things to yourself. If you think if this is a teamwork, right? It's a critical event. Everybody's is all hyped up, so it's kind of hard to remember everything. So you gotta help each other out. You gotta, your information might be very vital at that point. So don't think about hierarchy. Dr. Alexander is so cool, so you don't have to worry about that.
And somebody did do that with the defibrillator, because I know that the algorithm calls for 150. Dr. Alexander said 200, and somebody did check back 150 and then switched it to the 200 that Dr. Alexander wanted. So that was a good check back, yeah.
But I like that 911 was called early. I keep hearing, do we
Yeah,
still
I mean,
have
it
a
was
pulse? Do
great.
we still have a pulse? So somebody was like keeping an eye on it because we are having a difficult airway situation. So that it might put you in a tunnel vision for people managing the airway. But somebody else was also got your back because they were like, do we still have a pulse? We still have a blood pressure. And I heard a lot of closing the loop, like we've done this, we've done this, we've done this. This is their current vital signs. We're still at this set. We still have a pulse. We still have a blood pressure, and that was what we were talking about that situational awareness, where we're all speaking the same language. We're all taking care of the same, patient. Okay. Anything else anybody want to add?
I mean, I hear such good things from everybody, but I'm still confused and lost. I still feel like I feel like I was just standing there. Personally, like I'm like, can I help? What should I do? And so when you ask for the
ET2,
the math 7, whatever 7, I was like, I don't even know it's like. So I'm still sitting there like, if he asks for something, I don't even know what it is. What it's, how you use it, or am I the only one?
So if you don't know something, then what would you do?
No, I mean, but that was in the code situation, but like for now, as we're debriefing, can you explain like what the thing, you know, what the.
Oh yeah, definitely, that's part of the.
But just to
I'm
go,
not trying to be.
no, but just to go back, in a situation, in a code situation, it's where everything is urgent. You've been asked to give something or to bring something, you don't know what it is.
Right.
Say, I don't know what that is. Don't try to figure it out on your own. Hey, I know I've been asked to get E22, but I don't know what it is. Then it prolongs but you don't know what it is. So you have to say, I don't know what ET2 is. Can someone tell me what it is? Where is it? In that case, someone who understands it can come and say, hey, you know what? ET2 is on the 3rd floor and the 3rd drawer, and this is what it is, and they can get it. So there's no, guys, if you don't know something, to say, I don't know it is not a problem. At this time, it's about the patient. It's about to make sure that we get all the resources we need right away, and then the education will come later. There's no penalty to it.
Because I mean, I'm the type of person, I need to see it, feel it, touch it.
Right.
Not taste it, but.
So we were hoping we'd have a little more time with the carts, but our time beforehand cut down the time that you guys had with the carts open. And this is something that an anesthesia tech would, but it is good for you to know what the doctor is asking for in case they're not there or they're busy with another case. But we can bring them back out there after we do the next simulation, and we can spend some more time going through it.
Yeah, and that's the thing we want. Like you say, I don't understand it, so that's something we can take back and actually do it, you know, after the simulation or, you know, at a different time to say, okay, this is what we don't know. So you just found out, like, you know, maybe I need to familiarize myself, or we need more education on this, and that's exactly what we would like to see. It's like, hey, I need to increase my comfort level, and that's I'm very glad you spoke up.
Will you guys do simulations?
We do
or in the headquarters or whatever it's called?
Maybe Michael and Dahlia come and help with
the Michael and Dahlia. Yeah, we do simulation in the in ASC, CDU, IR.
It's part of endoscopy. We do that too.
Is it possible that we do this every 3 months?
Yeah, something. We need something like this is. I mean, in a month or two, I'll forget.
I hear you.
I know.
Job security.
No, we totally hear you. And it's not unique to this, yeah. Go ahead.
Yeah.
How often does ENT respond to the situation?
I know that there's been at least 3 cases at 3 different centers that they've at least been to this year. I know that there's been 3 events that they've had to come and assist with. Now, that doesn't necessarily mean trach, but it could, like, sometimes the thyroidectomies will have swelling and we have to go in and evacuate that. But they are available so while the rooms are running.
This is my first awareness that is even an option to do. So I guess to speed up getting that assistance.
You probably weren't here. I came one day and we went over the difficult airway code and calling ENT. So, and I can go over that again. We can go over and that's part of what we did it came up on the screen. But there is, this was not attached to the cart a couple of weeks ago. And so I made copies of it and I laminated it so it's a difficult airway algorithm. And then this is going to tell you who to call. This is the best copy that I can get, but it tells you what the ENT number is at Largo. So everything is right here. You can grab this and call who you need to.
And that's part of operation. So if knowing that number is critical. So if you have a patient that's coming in and you think it's going to be a difficult airway type of situation, then just make sure you have that number available somehow. And
You should
Do we put 79 star or is that just
It should be 79 here.
So we just pick a phone and dial 79.
Yep, and then it will hear a beep and then you'll state what you're.
I actually have it printed like every numbers, and I'm just gonna laminate it next week. Put it in everything.
at the point where You were having.
Yeah, you can disconnect that, because I'm gonna put the cards away and let
Should we
the next
have
one come.
recommended
Yeah.
the full board?
Oh, yeah, you can, yeah, and that's, you could recommend a Buki, you could recommend the fiber optic, you can say, can I get the gliding scope, if you're having difficulty, LMA, any of those for superglide airways. So any of those work.
You gotta get this replaced. Sorry.
All right, your turn.
Sorry.
No problem. Thank you so
All
much.
right.
Back on the hall.
Another round.
Oh, fun time.
Great job, team. How about I'm doing one thing? Good job.
When I was in the ED, the doctor always said, write it. That's what I got it.
Okay.
This is
That you sound like, oh, I do it every day, and you're right. Say, this is why I or you can challenge it again to say.
I'm gonna tell
but
Deb.
ACLS says.
You don't want to have to wait too many times.
And if you really
That's
think
okay,
that,
don't worry about it.
Right?
Well, we do it in the ED too.
There's lots of
The doctor override it every time.
Yeah, because they get all excited and like, that's your pulse check. Like, no, you're supposed to be
And first epinephrine is after 4 minutes.
You want to just, the energies.
Okay.
You deliver it because it's a refib arrest.
And
Energy should
shock
have been
first, and
shock
then
first.
after first 4 minutes, that's the first epinephrine, and then we're on the
Then you
road.
offer,
Then epinephrine.
but yeah, they still go back to their old habits. Yeah.
Alright,
We
thank you
always
very
talk
much.
about
no? You want us to come every 3 months?
Yes, I can do that. No, seriously, because
I mean, we would like to, but you know, there's like always this educational time that you guys don't have, and it's you know.
well, if this is for the training of the staff, we can recommend it.
Yeah,
And-
please do.
and-
We've been talking about this. At least you should have an education time, so that you know we can come in and then you have all the team that you need, at least to go through it a couple times. You know, I mean, it's something
Other
you need.
team? Sure.
Let's put everything away.
At least 3 months, right?
From what we've seen, that's something that you need. You're,
Thank you very much.
no problem.
He's in charge. Yeah, he wanted us to do like one-on-one codes, which I told him like just the 2 people in the room and just do. I was like, we just don't have time to do that.
Like every 2 person.
Yeah. I was like, would we be here all day? I said, I thought we did as a half day.
He's very good, but yeah, I don't know.
He was very good though.
He is. He's in charge in that sense. But the person I had, so the person I had doing consciously, they're the ones that are going to be a little bit more anxious about this. All right, so I'm going to go get the other group.
No, I can
Thank you guys.
No, you're welcome.
Is it okay to do it all on one sign-in sheet, the difficult airway and the simulations? Because I have them designated A group, B group.
Yeah, for us, it's fine. That's
For us, it doesn't matter.
Okay.
Well, she, okay, I'm in the ER. It's not common knowledge. So. first one. Because he's trying to go out and out, right?
I think we don't need to do anything.
And they think we don't need to do anything.